Welcome, everybody, to the PDS webinar, Strengthening Cardiology Practice Performance from Data to Insights. My name is Scott Everett. I'm the Vice President of Healthcare Solutions here at Practical Data Solutions, and I'm joined by our CEO today, Russell Hendrickson. Welcome, Russell.
Welcome. It's great to have you with us today. For those of you who are new to our webinars, throughout the webinar, you can ask questions. Just use the chat Q&A tool, which is at the bottom of your screen. And certainly at the end, we'll also be taking questions. So feel free to chat in your questions at any time throughout this webinar. If you're unfamiliar with Practical Data Solutions, we specialize in healthcare analytics, reporting, dashboards, and visualization tools. And we're going to be talking about the three different areas that we find in healthcare, which is operational analytics, clinical analytics, and financial analytics. And so with that, let's jump right into today's learning objectives.
So as we go throughout our webinar today, we want to talk about some customized KPIs that a lot of cardiology practices are tracking right now so that they can stay competitive, deliver high quality care, and really be financially viable. We're going to use ways that we can utilize visualizations in order to communicate those metrics out to key stakeholders like management, executives, and providers. And then we want to talk about performance opportunities. What does that really mean? How can you utilize performance opportunities to drive change within your organization and really become high performing? We want to talk about some of the software tools that are out there and figure out what's best for your organization and your unique challenges and goals. And then, of course, we're going to talk about being data-driven. And really, that's kind of the key. We're trying to help others become more data-driven.
So let's talk about that, Scott. What does it mean to be data-driven, right? Moving from data to insights. Instead of just using reports or looking at past performance, we're trying to use data continuously to uncover opportunities, performance gaps, ultimately to improve performance. And that performance could fall into, a lot of different areas, whether it's just ensuring that our patients are having a good experience in the practice, or it could be ultimately the bottom line. How do we make sure we're getting all the revenue that we're entitled to based on the work that we're performing? In order to be data-driven, though, and probably part of the reason why you might have come to today's webinar is, why don't the standard reporting tools that you have with your EHR or your general ledger, why don't they deliver what you need for a cardiology practice?
Yeah, I mean, there are a lot of tools when you're looking at canned reports that come out of a billing system or an EHR or even from a third-party sources that are out there. But cardiology practices really have some unique needs that aren't necessarily sitting within a generic billing practice or the canned reports that come out there. And so we want to talk about some of those specific metrics that may be of interest to particular practices. Normally, patient counts can be something that can be difficult to get. They may be difficult to define. You may have service mixes where you have subspecialists, you have invasive, non-invasive, interventionalists, things like that, and you want to track those a little bit separately. You want to track your imaging, studying, testing, and looking at costs, looking at your staffing ratios, and of course, big part for cardiology practices is referrals. Where are our patients coming from? And so looking at that is something that is specific to cardiology and may not be found just within a system itself.
So we like to break down cardiology performance and break them down into what we call the 5 cornerstones, which is patient experience, operations, finance, clinical, and then staff and employees. So with that, let's dive right in and let's start with the patient experience.
And patient experience is, it's great that that's right at the top, Russell, because patient experience is what a lot of people are focusing on right now. It's really the key. And what's funny is, as someone who's worked with in big patient experience initiatives, you can really see how when you put the patient first, everything else kind of falls into place. And so you really want to be measuring that patient experience. And it goes even beyond just the patient satisfaction scores themselves. It goes into kind of the correlating metrics of wait times and how easy is it to get an appointment, and even what's the billing look like on the back end and the interactions with the staff. So this is really critical for everyone to understand. Again, we talk about patient experience with our surveys, and this is where we really want to kind of understand, looking at maybe even some specific questions within those surveys themselves to understand what we're looking for and what are our patients saying about us. But it goes even beyond what they're telling us. We receive patient feedback in a number of ways. I think it's really important to listen and document when they tell us things immediately and look at what they're saying about us online. Really, those online patient reviews are pretty critical.
Yeah, I mean, online today, especially with this sort of internet generation, really critical. I like to start with the patient satisfaction scores, and when we talk about what are some of the KPIs for cardiology, the two that I like to recommend organizations really focus in on is, would the patient recommend the physician, and would the patient recommend the practice? Because there's quite a few different scores in your patient survey data, and just taking an overall patient satisfaction score, I don't think tells enough about what's really going on. But when you actually ask the patient, would you recommend us? If they're not saying yes, you have room for improvement.
Yeah, I think that one's really critical. And again, we talk about these other metrics that really drive patient satisfaction of how easy is it to get an appointment. That's really critical in cardiology. I know I talked to a cardiologist once who said, if you tell a cardiologist, that you can get patients in 3 weeks, they think that's pretty good. But if you tell a patient you need to see a cardiologist and they say we can't get you in for 3 weeks, they're like, I'm going to die. So really understanding that those lead times are really important on that one. That's a big satisfier. And then, of course, the time spent waiting in the clinic itself and how much time are they spending in the waiting room? How much time are they spending in the exam room waiting for the provider? Really, those are key drivers that we see a lot that really impact those patient experience scores.
Yeah, without a doubt, Scott. What's interesting though is when you ask patients what's most critical, you'd think it would be something like outcomes, but we found that's not actually what patients say.
No, it's kind of funny, really. When you look at those scores themselves, the biggest driver is customer service. How are they treated by the staff? How are they treated by the provider? When they call in, how are they treated by the call center? Really, customer service is the big one. What's funny is outcomes is third. It's not even second. The second one is the cleanliness of the office. So really the maid and the people answering the phone are driving the customer experience as much, if not more, than the provider themselves.
Yeah, and then going a little further, organizations like Press Ganey, one of the probably most widely used survey companies, they talk about patients now are looking at reviews more often than ever. Before they even pick up the phone to call a provider, they might even look at reviews over a recommendation from their primary care physician.
Yeah, I know. I'm trying to find a provider for my daughter right now, and we're looking at the online reviews. And I'll tell you this, she won't even consider one that has less than 4 stars. She's probably 4.5 is preferable. And so, really looking at that is it's good for you to dig in and look at that, find a doc, look at Yelp, look at Google, and understand what people are saying about your practice online.
Yeah, I mean, it's just so very important, especially if you've had one or two patients that are either very vocal or just really did have a bad experience. You want to make sure you can understand what they're saying and try to mitigate to that.
Yeah.
When we talk about being data driven, we talk about providing information. One of the big things we want to do, especially when it comes to patient satisfaction scores and the patient experience, is transparency. We want to make sure that the physicians, the practice locations, and the care teams understand what those patients are saying. And you can take sort of off the shelf reporting, but if you put something like this in front of the physician or the practice and say, this is what they're really saying. We've redesigned the way we're using data to communicate to really understand those performance gaps. We've highlighted front and center, would the patient recommend the physician, and would the patient recommend the group? In this case, this data is saying, yeah, most patients really like the physician. We can see maybe they weren't so happy with follow-up care or feeling that they were involved in the decision. When we look over on the right side of the screen, we can very quickly see they're not happy with communication over the phone, how easy it was to get an appointment, and even some cases not feeling that the staff is courteous. And that's something that's easily corrected. Right. And so having good dashboards, good data, we go back to being data driven, trying to make it easy so everybody understands what's going on in the organization and has the information they need to self correct.
So let's talk a little bit about some of the operational things that really dig in and drive the patient experience when we start talking about this. And we're looking at things like patient count and scheduling. You know, we talked about how important patient access is to the overall patient experience. So looking at scheduling and then looking at, you know, some of the ancillary services and the overall services that we're providing so that we can better understand, should we market to certain services that we're really good at, or you know, look at improving other services that may not be as profitable for us.
So let's look at some of what we consider the operational KPIs that every cardiology practice has to be measuring.
Yeah, and so again, let's look at scheduling. Let's look at the appointment booking lead time. How quickly can we get new patients in? How quickly can we get established patients in that call with you know, an urgent care situation, things like that? Are we doing a good job with our follow-ups? Patient no-show rate is something that we need to understand as well, because that can either provide additional capacity, and it's something we probably want to mitigate a little bit.
Yeah, and then going further, are we getting patients in for screenings and follow-ups and following appropriate preventative care guidelines? What are the diagnoses or HCCs that the patients, that have cardiovascular conditions, what are we being asked to treat, and where might we need interventions? And then ultimately, what are the mix of services that we're providing? And do we have appropriate access to those services? Maybe we've got a lot of patients coming through, but we don't have enough, in-office EKGs. And so understanding, does the procedure mix that we're performing, potentially even our room layouts and the staff, we need to support that. Is this all helping get the patients through appropriately?
Yeah, and we probably want to track if we have any ancillary services that we're looking at, particularly things like home health or device monitoring services that we're providing, in addition to maybe, you know, rehab. And of course, any imaging that we're doing can be a big revenue driver as well. And then we want to look at patient retention. You know, we're cardiology, we're dealing with patients with chronic conditions, and are we finding appropriate follow-up care? Are we tracking patient compliance with their health plans and their medications and things like that? So really looking at this patient retention. Are our patients coming back to see us?
Yeah, and Scott, patient retention again, hand in hand with patient experience. But let's
Mm.
talk about counting patients, because even that can sometimes be a stumbling block for organizations when you think about what is the data we need to understand what's really going on with our patients and our patient mix.
Yeah, and so, you know, we can talk about things like, you know, our overall panel size and things like that. But when you talk about patients, you know, new patients, established patients, unique patients, there's lots of ways to look at it. And then, of course, it comes down to everybody wants to know, well, how many visits did we have? We have clients that have dozens of different definitions of what is a visit. Is it something that comes out of scheduling? Is it something that comes out of billing? Is it something, you know? And so really some of the ways we've broken it down, you know, a visit is one patient, one provider, one data service, but maybe a patient comes in and they see a couple of providers during that time, and that might be an encounter. A case is a patient with certain CPTs that we did with maybe in the cath lab or something like that might be a case, but an episode of care may include a diagnosis that we're tracking over time. And so looking at all of these different patient care metrics can be telling for certain areas in your practice.
Yeah. And what we don't have on the list here is, what if you have a visit that doesn't involve a provider? What if the patient's
Yeah.
just coming in for a blood pressure check, right? So a lot of organizations in particular, when we think about having data, we don't want to have to dump data into a spreadsheet and spend hours trying to massage it to get to the definitions that we need to manage effectively, right? We want to have these definitions designed so it's a button press. And we'll talk about tools and access to data in just a minute, but let's focus on some of the other key operational areas that we've touched on. Scheduling, number one, right? Both for patient
Mm.
experience and for getting those patients in and through. If we don't have good scheduling optimization, we likely have problems both financially and with the patient experience, right? So looking at things like appointment lag, arrival rates, obviously trying to manage cancels, no shows, and bumps. Real big area there that can be, if there's issues going on, we could highlight and we can do something about it if we understand what's going on.
Yeah, and taking these metrics is one thing and having them available, but we need to really be able to communicate those out. And so if we look at, you know, a visualization, A lot of the tools and technologies that are out there allow us to take these metrics and visualize them for the staff. And so, a lot of times I look at something like this, and if I'm working with a client on patient access issues, the very first place I'm looking is at those session statistics that you see up there, because that shows me I've got capacity. A lot of people think, we're having trouble getting people in because we're just fully booked. The session statistics tell a different story. I also may want to look at provider utilization. Who are the providers that are not necessarily at capacity, as far as the amount of minutes that they have available in their template? How many of our providers are booking more time than is available in the template? And can we spread the work out a little bit and find some availability that way? And then, of course, looking at, third next available, how quickly can we get patients in? Appointment lags, how quickly did we get patients in? Why is there disparity between the two? So really digging in and communicating these out can help us to begin the process of improvement.
Yeah, and then appropriately too, we want to make sure that we've got, if it's down to the physician and we want the physician to understand what metrics they have control over, we want to make sure that our data, our reports, and our visualizations allow us to deliver to the physician or to the care team the types of metrics that they want to see. Now, this is a great example of an interactive visualization, but how might we put some of these operational metrics back together and tell a story, potentially for our monthly or quarterly leadership meetings, where we really want to understand what's going on and where we're using and what kind of services we're delivering?
Yeah, so sometimes rather than doing the web visualization, it's easy just to send out a static report every month to each provider to communicate how well they're doing, or maybe a medical director or a clinic manager, and understand various important metrics. And so we can look at things like, what are the top procedures that we're performing? What are the different imaging studies that we're utilizing? When we have our visits coming in, how many are going to our non-invasive group versus our interventional group versus our electrophysiology group? Look at new patients. What is our appointment lag, and what's the trend of that over time? Are we getting better? And then, of course, you look at something like escalated care, our readmission rates. That's a really key quality issue, that we want to look at, especially when we're seeing patients in the hospital. And of course, having patient satisfaction front and center. I think if we're, again, focusing on patient experience, patient satisfaction scores need to be on pretty much every report that we're distributing.
Yeah, and Scott, you bring up a good point. I want you to notice on this dashboard that we're looking at a lot of different data types, right? We're looking at visits, we're looking at appointment lag, we're looking at procedures that were billed, we're looking at imaging, some of our testing. We might be integrating readmission rates that might even be coming from the hospital. And then, of course, as you said, patient satisfaction data with referral data. So to be effective, dashboards need to be able to communicate all of those different metrics together to tell the story, right? And we might be performing well financially, but if we're not addressing our patient satisfaction, ultimately we may be hurting the practice. So let's transition a little bit though, because we're kind of headed in that direction, and talk about the third pillar, which is how do we strengthen the bottom line, right? And there's really three key ways that we can go about strengthening financial performance. We can see more patients, you know, provide more access to patients. We can improve our reimbursement, negotiating better payer contracts, looking at our coding, and ensure when we get denials, we're collecting all that money. Or we can think about getting paid faster. We can collect copays or deductibles, and even making sure that we're getting paid by the payers in a timely fashion, which ultimately impacts cash flow. Which leads us to our third pillar, which is financially, what's going on? We look at our revenue cycle metrics, our contracts, our payment lags, our denial management, and then even our margins where we're going to want to integrate. So, Scott, what are some of the key financial KPIs that every cardiology practice needs to be mindful of?
Yeah, I mean, the biggest ones that people look at is revenue, but I like to look at it in kind of a revenue per visit type of thing, and I want to break it down by the different visit types that we utilize, because that gives me good information in terms of what are the services that are really driving our bottom line. We want to look at payer mix, and probably even payer mix from our different referral sources, so that we can see what's coming across. Do we have any value-based contracts that we're managing versus fee-for-service contracts that we're utilizing as well? And then, of course, are we getting any additional reimbursements for quality or chronic disease management and things like that? Those are really critical to understand for every practice.
Yeah, certainly want to look at our collections ratio, right? And how our revenue to bill charges, understanding how quickly we're turning charges into cash. Obviously, days in AR. Most organizations usually doing a pretty good job looking at days in AR, but if we can break it down or even filter out AR that relates to testing and related services, that may be helpful to understand the profitability of certain services. And of course, we're going to talk about denial rates. Number one leakage in any practice in cardiology is denials that are never recovered, right? And especially focusing in on those high cost procedures and making sure that we're getting paid and paid correctly. And then point of service collections, right? How effective are we in collecting the patient responsibility? You know, whether it's copays, deductibles, or out of pocket amounts that the patient might be due.
Right. And then we want to look at any revenues that again are coming in from those ancillary services that we're providing. A lot of times those may be tracked separately in different systems. And so we want to make sure that we're integrating them into our overall financial understanding. And then of course, overhead, we want to start not just look at our revenues, we need to look at our expenses as well. We want to make sure our ratios are where we expect them to be. And then we want to focus in on like key high level expenditures beyond salary and space. What are these other high level expenditures that we have, and are these necessary, and are there ways to bring things down?
Yeah, you know, just critical that we have alignment with our general ledger and of course our service mix and the procedures that we're billing for. Often though, when we talk about profitability, we have to come back to RVUs. Now, if you're a private practice and maybe your compensation model is more, you know, paid out based on revenue or collections, you know, that's great. But the reality is RVUs are just critical because most payer contracts, even if they're value-based care, they've all, you know, stem around what Medicare is doing with fee for service, right? So being able to understand RVUs appropriately and have them specific or customized to both how you need to report, how you may want to measure physician productivity, and ultimately how you want to measure compensation. Very common today for organizations to have multiple sets of RVUs that they're using.
Yeah, and so we actually work with clients a lot of ways because a lot of times the billing system can only calculate RVUs one way and it doesn't give them exactly what they want. Modifiers is one example where sometimes modifiers are customized by payer within an organization, and so they may need customized modifier modifications. Um, Contract specific RVU variations that maybe they're unlisted codes, pseudocodes, especially if you're a tertiary care practice, you may have codes that aren't necessarily listed in the CMS tables and you need to have RVU values brought in for that. RVUs may be different based on your compensation plans, things like that. And of course, you may be utilizing a benchmarking service which calculates them differently as well. We actually have some clients, Russell, that utilize 4 different RVU calculations within their practice based upon the different needs and things that they're trying to report against. And so sometimes you do need those customized calculations that just aren't able to be done within the billing system.
Yeah, so let's go ahead and take a look at a visualization where, you know, we're sort of looking at reimbursements. We may want to look at reimbursement per work RVU across our major payers. We may want to be able to look at things like underpayments from the payers where we know we have our fee schedules and are we collecting what we should be collecting. Ultimately understanding, you know, even how quickly are we getting paid? Are we getting paid to contract? What are our denial rates? And then that all important denial recovery rates.
Yeah, really denials is key. We can talk about how good our contracts are with our payers and what we're getting reimbursed either as a RVU conversion factor or as a percentage of Medicare, but nothing drives down actual reimbursement as much as a denial does. And so if you look at denials, that really is kind of a key to make sure we're mitigating that to get reimbursed as much as we can.
Yeah, I mean, the number one area of leakage within a cardiology practice is, you know, unrecovered denials, and it's just so critical. Let's go ahead and take a look at a visualization on denials.
So tracking these denial rates is really key, and looking at it by, individual location or subspecialty. I think it's important to understand that denials aren't always on the payer. Some of these denials are on us, particularly eligibility denials. Are we doing a good job at the front desk of collecting accurate information, insurance information from our patients every single time? Are there things that we're doing from a documentation standpoint that are getting denied frequently that we haven't changed the way that we're doing things? And so understanding those denial sources, understanding the trends, and if we're putting things in place, we want to make sure those are trending downward.
Yeah. In addition, we talk about cash flow, right? And so the time it takes to get paid, there's all these different areas where we have potentially delays in getting payment, from how quickly did we bill the charge to how quickly did it get billed out to our, if we're using a billing service. Maybe something hit one of our claim edits and got held because we had to correct it. And then ultimately, from the time it finally gets to the insurance company, how long does it take for the insurance company to adjudicate the claim and send it back to us where we're collecting the money? And so when we think about these lag delays, right, if we could shorten even just one day, right, we can collect a lot more revenue within a quarter or within a year. Scott, I know you talk about this quite a bit. What happens if we shorten just one day?
Yeah, if you shorten one day in one of these areas, this year we'll collect 366 days worth of payments rather than 365. That can be a pretty big deal for a practice, but think of it now, if you can find one day in each of these areas or multiple days in one of these areas, now all of a sudden you're collecting 370 days, 380 days worth of payments in a year, and that's a big deal. That's going to strengthen your bottom line and your cash positioning considerably.
Yeah, when we talk about the ROI for analytics, not only will it strengthen your cash position, but if you think about analytics as an investment right away there, you can usually easily pay for some better tools and the metrics you need to really stay focused not only in collecting them, but then maintaining those reduced payment lags
Mm.
and timings. Right. So again, let's talk about what might we want to put together. What might a financial dashboard look like for a cardiology practice, where we want to try to summarize what's going on?
Yeah, so most practices right now and most billing systems will give you your charges, your payments, your adjustments in a cash position, what was posted during a given month. And obviously you want to be able to look at those trends and make sure they're trending in the right direction. Appointment statuses are going to correlate to those as well, seeing your appointment volumes increase. But then you can also look at things like your payer mix, your average charge lag, how quickly are you getting your charges in, your days in AR, how fast are you getting paid once they are in? And then, of course, your denials and tracking those denials and making sure that one, our rates are either stable or going down, and two, are we collecting when we do get denials?
Yeah. So a nice summary. And again, you'll see this would recommend that patient experience score, trying again to make sure that we're thinking about that even when we're looking at our financials, right? Because if we don't have good patient experience, we're going to see financials, we're going to see poor performance coming if it's not coming today, without a doubt. But speaking of performance, let's talk about outcomes, right? Because clinical outcomes are critical, both for the success of our patients, that we're delivering quality. The payers now are bringing quality metrics to the table, and we may even want to be looking at certain specialized services that we're bringing to the patients, and how are we performing against the benchmarks and the quality standards that exist. So what are some of the critical clinical KPIs for cardiology practices that everybody should be measuring?
Well, I mean, outcomes is the big one that we want to look at. Our treatment outcomes. We may even want to break it down into, a single diagnosis like our heart failure outcomes, because that's a big one that's important to really track. We want to look at readmission rates. I think that may be the critical quality indicator that cardiology practices are looking at quite a bit, is readmission rates for patients that they're seeing in the hospital and things like that. But then looking at, diagnostics, looking up follow-up care, all of these things are really driving our quality of care.
And then, to go a little further, utilization of our ancillary services, right? Again, going back to, what treatments are we offering? What kind of monitoring? If we're offering any kind of, rehab participation, what are some of those services that potentially, are quality issues, but are also really can relate to the patient experience and the patients having all the services they need coming from, their physician that's providing the care and really looking out for them. And ultimately that's going to impact, you'll see it again here. We keep talking about it, that patient experience, patient satisfaction scores. Where might you start if you're not able to measure quality metrics? Because quality metrics, Scott, oftentimes we'll hear we can't get data out of the AHR, or we're kind of limited as to what we get, or we're only really looking at what the payers are telling us we're doing, which oftentimes is only half the story. So where might we start with quality metrics?
Yeah. Where to start is really kind of a difficult question because every practice might be a little bit different. But if you don't know um, a place to start, a good place to look is starting with the MIPS metrics that are out there. Even if you're not participating in the MIPS program or the MIPS plan, those metrics give you things that you can measure as far as quality that's out there. And so looking at, the number of patients that might be eligible for these, or looking at the overall MIPS metrics and performance over time. You can also look at individual providers and how they're scoring against either a very specific question or a MIPS metrics, 5, 10 MIPS metrics overall. How are they performing with regard to a target or with regard to the average of their peers within the clinic or the department?
Yeah. And, as far as quality metrics that the payers are reporting, if you're getting paid on any set of quality metrics and you can't quickly and easily understand how you're performing throughout the month, there's a great area where you're probably not being data driven. You need to understand where you're going to end up with those payer metrics before the payer comes back and tells you that you did or didn't hit them. Right. So there's a great area, for example, of being more data driven can have a huge impact on your financial performance. Let's shift over to the fifth area, Scott, and talk about employees and employee engagement.
Yeah, so if we really want to drive all of these factors, operations, finance, quality, as well as patient experience, we need to have engaged employees. We need to have engaged providers. We need to understand, maybe we're utilizing engagement scores and things like that. That might be a good way to track it. But really, those scores can be skewed a little bit. What really tells us how engaged our employees are is our turnover rate. And our providers leaving, our staff leaving, is it difficult to keep adequate staffing ratios in order to meet the demands of our patients? That's a big deal in terms of things that we need to be tracking because it can be a huge expense in addition to leading to these quality and outcome factors.
Yeah, just a real recent article too about recruiting physicians and the cost and time. It's taking longer to recruit physicians, and the costs of recruiting have gone up dramatically. Right. And then, another metric that we put in here that's kind of critical for, employee KPIs, we added referring physicians. Obviously, they're not really employees, but if your referring physicians aren't, happy with your wait times, with your follow-up care, and even your communication, that can ultimately impact, right, how the referrals that you're getting and how you're working with your peers. So it can be really critical to the success of the practice. Why is employee engagement so important, Scott?
Well, employee engagement is really critical in terms of what it does to the patient experience. If you don't have engaged employees, their dissatisfaction with the practice can impact the way that they treat the patients, and it can definitely reflect on what the patients are seeing. And so, multiple studies have shown that if you have more engaged employees, you're going to have higher satisfaction scores. It's a direct correlation every single time.
Yeah. And a lot of organizations, we were just speaking at a conference about this. A lot of organizations struggle with how to measure employee engagement, but there's a couple places that you might want to start.
Yeah, again, we talk about turnover rates and really understanding not just, how frequently our patient or our staff leaving. We want to understand what's it costing us when they do. Because if we bring in someone new, we may have to do a new hire bonus outlay. We may need to factor in recruitment expenses if we're utilizing third party recruiters, things like that. And then of course, we want to look at what may be going to that. And so we can look at things like disciplinary actions taken. We can look at things like that, but we can also look at scores that may come from our patient satisfaction surveys.
Yeah, all key metrics that you really want to be mindful of. And oftentimes, again, organizations don't really think about this as part of their analytics strategy. Let's talk though. We've shown you some different dashboards. We've shown you some interactive visualizations. Let's talk about the technology behind some of these things that organizations are using to be data driven, right? And you'll see right on the top of the graphics here on the left side, you see Microsoft. Microsoft Power BI is what everybody's talking about today. And in the past, it was Tableau. These state-of-the-art visualization tools that make it very easy to understand and put data together, to be able to tell a story with the data, but also are interactive so the user can actually look for performance gaps and then understand where things are working and where we see those performance gaps.
Yeah, so really what's important is what we consider the analytics trio. And what the analytics trio does is it allows you to go from the visualization, which is an easy way to distribute information to key stakeholders and have them digest it. But then we want to be able to understand when a visualization leads to questions. We need to have an analytical piece that allows us to do quick slice and dice through the data in order to identify outliers and find out, why are things happening rather than what's happening. And then, of course, we may need to get down to the detail level as well. And what can make it difficult is if those don't speak to each other, you may have to do 3 different queries or 3 different reports in 3 different tools in order to get the answers that you need.
So let's look at a visualization here where we're correlating things like the work RVUs, the performance of the physicians. Everybody to the right line here, they're performing more than 400 work RVUs per month. Everybody to the left side of the line isn't. So we can very quickly point and click and highlight performance on RVUs, right? But then we go further and see, well, where are we getting physicians that are turning in their charges late? And so just by highlighting these 2 boxes, we can start to see where we have poor performing physicians that are also turning in their charges late or have low volumes of appointments, right? And then to go further, we may even then want to see, and where do we have low patient satisfaction scores? And so these interactive visualization tools are now highlighting poor performance, low patient satisfaction with scheduling, and we can start to very quickly start to call out where do we see performance gaps, because as we work with the tool highlighting different areas of performance, it makes it very easy to see where we may need to focus. Another view of the same data, we may even want to integrate things like years of service. Why? Well, because what we found is that physicians that you've been training and trying to communicate, hey, we need to change our how we're following up with patients, or we may need to make sure we're getting our charges turned in quickly. Those physicians that are newer within our practice, they may need more training. They may not quite understand how to run the systems. They may not have workflow down as smoothly, potentially as physicians that you've been working with and training in, yet we're still having performance gaps in a lot of different areas. So we talk about being data driven. This is really what we're talking about, making it easy to both explore data, communicate data, and drill down into the details to really understand where we need to make changes, right? But this tool, Scott, might not be exactly what we want to show a physician, right? Might be almost overwhelming, probably great for leadership or anybody who's really trying to understand. But what might we want to do for the physicians?
So for physicians, a lot of times what we want to do is take these key metrics that we're trying to drive change on, and we want to communicate those out and do so in a visual process, but we can do it in a static way as well, either through Excel or PDF reports or things like that. But really what we want to do is make sure that it's visual so that they can see immediately trends in key areas. They can see things like net revenue or coding curves that are interested to them, their particular service mix that may be driving their practice. But really, what's important to them is these key metrics for the practice, but also, what is it that they get paid on?
Yeah, and so often we hear probably one of the largest complaints from physicians about what's going on in their practice is lack of understanding with how they're performing and directly how that relates to their compensation, right? So often compensation reporting is completely separate. It's a completely different set of reports, different set of metrics than they might be getting in their productivity and quality reports. And so we have to move, if we're going to be data driven and provide transparency, we have to move where it's one tool set. Everything is working together. Whether we're looking at productivity reports, we're looking at follow-up chronic care condition type reports, or we're looking at physician compensation. We want to make it easy so the physicians can understand what they're earning and how their productivity relates to their performance and ultimately to the bottom line of what they're getting paid.
Yeah, one of the best ways we found to do this is to really be transparent and clear with what's going on. Show them exactly how their compensation is being calculated. Show them the trends over time of how they're performing, what that does to their compensation calculation, and then give them some correlating metrics to say, this is what you're reimbursed on, but if you improved this area or this area, then that would improve your compensation. What they really want is to be able to self-manage. They want to be able to understand where they are and what they need to do in order to get to what their personal target is for their compensation.
Yeah. And what's so critical to all of this is understanding benchmarks and budgets, right? So when we think about the different areas of using analytics and we think about how are we going to improve performance, it's not enough to say, well, we're trending up, so we know things are good. It's not enough. We need to be able to benchmark. We need to be able to benchmark internally or externally. And ultimately, if we're going to do any kind of projections analysis, we need to be able to blend and correlate that data so we can understand. The key here, though, when we really want to measure performance is that benchmarking. What are we using for benchmarks? Are we using internal benchmarks where we can compare the physicians to each other? We can compare the point of service collections at the front desk between our different locations. We can look at our contribution margin across different service lines. So, we can internally benchmark and start to understand where are our outliers, either based on where we've been or based on our budgets.
And so some of the ways that you can improve as well is by looking at things externally and comparing our practice to really become a high performing organization. We may want to see where we match up in certain metrics based upon, best performers with the American College of Cardiology or HFMA, or we may want to benchmark against MGMA or FPSC if we're an academic medical practice. There are external benchmarks that are out there related to productivity, related to finance, related to billing, related to quality. And so really high-performing organizations are looking at these external benchmarks. And this can drive something beyond just providing context to these metrics. This can also drive performance as we move along.
Yeah, we keep talking about performance and identifying performance gaps, but can you walk us through, Scott, what is performance opportunity? How do we measure that? And I don't care if we're looking at it with RVUs, contracting, quality, how do we measure performance opportunity?
Yeah, performance opportunity is really a way to utilize benchmarks and compare people and then ask ourselves what if, and put some predictive things in place where we say, we have these metrics of our providers within the organization. We have our high performing providers, we have our middle performing, and we have others that are struggling a little bit. And ask ourselves, what if we were able to take those providers that are performing less than average and bring them up to average? Or what if we were taking the ones who are at average and bringing them up to the high performing levels? There's going to be a financial return that is out there, no matter what we put it on, whether it's a scheduling statistic like patients per session, or if it's coding curves, or if it's RVU productivity. Looking at this as a way to help drive performance, because there's going to be financial impacts to simply improving up to the next level.
Yeah, and this is an area, that oftentimes people say, well, that looks complicated. How do we do that? It can actually be done fairly easily once you understand sort of a formula to it, right? But let's actually look at a visualization where we've calculated that performance opportunity. And what you're looking at here is these are all the physicians, and we're actually calculating the number of visits per 4-hour session. So these physicians on the left side of the screen here, they're seeing, more patients than these physicians on the right side of the screen. And then we've actually benchmarked in the department average of how many patients are being seen in a 4-hour session. What's neat about this visualization, though, is if I just highlight and say, what if these bottom 5 physicians just moved up to the divisional average here? right? You can see right on the screen, you saw it recalculated. It's actually telling me that the average revenue opportunity for visit for all the physicians performing below the division average is 54,000 per physician. In this case, with these bottom 5 physicians, because they're the lowest performers, it moves up to 77,000. So, calculating what is the performance opportunity helps drive change when we can say, look, if we could just move, even if we could move 10%, if we could move those physicians up a little bit, how is it other physicians are doing it? We like to say shed light, not heat. It may be we don't understand. We have to look deeper into the data, or maybe it's training, maybe it's education. But by having data, we can start to think through why is there a performance gap and what are we going to do to try to drive change?
So I think, Russell, really what we're talking about is the key is giving data to people who need data. And if we want to be data driven, we can't hide the data, we can't make it difficult to get to, and we can't make it inconvenient to get to. We can't make it so that someone has to go ask someone else to give them a report and wait several days in order to get the information. They need to be able to self-serve. They need to be able to drive uh, drive the initiatives that they're in charge of, and they need to be able to track how well they're doing, and they need to be able to do it quickly and in a timely fashion.
Yeah. So to kind of summarize, do your users have access to the metrics that they need? Does management have the insights that quickly identify the performance gaps? Do physicians, staff, right? Does everybody understand where those performance gaps exist? And how are we, making change? Are we driving better goals? Are we driving down those performance gaps, ultimately improving our operational, our financial, or our quality experience for the patients? And ultimately, is the data available quickly and easily? Are reports automated? Are alerts available? Right. So I sort of challenge you, if you're not able to say yes to these questions, encourage you to reach out to PDS. We've helped organizations all across the country for over 25 years improve access to data and drive better performance, which is the whole reason why we want to improve access to data. And if you think about those different cornerstones, there's really not one area that PDS can't assist your organization, be it improving your patient experience operationally, financially, or clinically. So I certainly encourage you to learn more about PDS. We'd love to hear from you if you think you have just one area that we've touched on, or if you're really struggling with an analytics strategy and might need some help. How do we improve and become more data driven? We'd certainly love to speak with you and help you in your analytics journey.
So thanks, Russell. So with that, we'll go ahead and take your questions. If you have any questions, please chat those in. We will stay online and address your questions as they come in. And thank you for joining us today, everybody.